Tips and tricks for direct and indirect composite fixed dental prosthesis. First, I want to ask everybody that's following us today in this webinar to follow us on our Instagram and Facebook page as Romero Dental Seminars. We also want to thank our sponsors for today's webinar, Colteen, Oral Arts Dental Laboratories, Romero Dental Seminars, and Dent Logics. We want to thank them for allowing us to provide one free CE credit to all participants. Don't forget also to visit our webpage, www.romerodentalseminars.com. When you visit the webpage, please click on the link Webinars, and then click on the link that says CE Quizzes. You will be able to then download the CE quiz that corresponds to today's presentation, fill out the information, answer all the questions, and email it back to us at romerodentalseminars@gmail.com. Don't forget to subscribe to our YouTube channel, Romero Dental Seminars, where you will find over 100 hours of continuing education. And two videos that we want to recommend for today's webinar, just so that you can make all these topics come together, is our tips and tricks for fiber reinforced composite and our tips and tricks for basic rubber dam isolation. These two webinars will help you understand many of the clinical steps that we're going to be sharing with you today. So our learning objectives for today: first, we're going to help you identify the different types of clinical techniques available for fixed prosthesis. Understand the steps required when using a prefabricated post for direct fabrication of a composite fixed dental prosthesis. And understand the steps required for indirect fabrication of a fiber reinforced composite fixed dental prosthesis. So let's go into our tip and trick number one, the clinical techniques available. Well, as I mentioned in my learning objectives, and the whole idea of this presentation today is to learn how to solve issues of our patients missing some teeth without having to go to a ceramic restoration. So this would be a fiber reinforced composite fixed dental prosthesis. And there's two ways that you can do these prostheses. And again, I wouldn't consider them as a definitive prosthesis, even though I have patients right now that have some of these prostheses for 7 to 8 years. It really depends on case selection and obviously how good you are to elaborate these prostheses either directly into the patient's mouth or at a lab setting. And I'm going to share with you both of those options. So option number one is obviously a direct option, where you can either use a fiber reinforced fiber post, like the one that you are seeing right here on this image. This is the one that I'm using in this particular case, is a Parapost fiber white post, and that's definitely one option. Another option would be to use a glass fiber, and you can bond this glass fiber directly into the patient's mouth and build a pontic around that fiber. Now, for this particular case that I'm sharing with you right now, I have chosen to use this fiber post, and there's a couple of reasons why I like using fiber post. The number one reason is because they are very resistant. They are very small in diameter. So my preparations, they do have to be intracanal. They have to be intracoronal. I'm sorry. You have to prepare slots within the tooth to actually bond this post in. But because the post is so thin, these preparations are very, very conservative. Another option, obviously, is a direct option using a glass fiber. Now, as you know, as I mentioned in my previous webinar, when I was talking about fiber reinforced composites, we do have polyethylene fibers and we have glass fibers. The one that you're actually seeing here on the screen is a glass fiber. This is one of my cases that I decided to use a fiber reinforced technique using one of these glass fibers. What I like about the glass fibers for this specific technique, when you want to do it directly into the patient's mouth, is that it's pre-impregnated. It's already covered by resin. So all you have to do is literally just bond it to the neighboring teeth. Normally, you have to have some lingual space. You could do surface retention, meaning that you can just bond this to the surface, the outer surface of the tooth or the lingual enamel, or you can also have some preparations done on the teeth and do them coronal. If you have, if you have some class 3s that you still need to restore on the teeth that you're going to use as abutment teeth. Now, I want you to look at the thickness of this glass fiber. And if you think about it, the amount of tooth removal or tooth reduction that I'm going to have to accomplish in order for them to make them intracoronal is going to be a lot more compared to using a fiber post. And that's the reason why I also like the technique of using a fiber post. Now, when would I choose a fiber post compared to a glass fiber? In a situation when I'm missing a mandibular incisor, like the case that I showed you before. Maybe for the maxillary incisor, you're probably gonna, you're gonna have a little bit more occlusal load, and for that reason, you may benefit from using a glass fiber that is wider, that would give you more bond surface to the actual abutment teeth. So this is again another option. In particular, I'm using here the Everstick system, which is one that I personally like for the glass fiber option. Now, you can also build them outside the patient's mouth. So again, there's two techniques, right? The first two that I shared with you are the direct techniques, meaning that the patient comes into your office, you sit him in your chair, and you actually fabricate the prosthesis directly into the patient's mouth. But there's another option that I like using for more complex cases. And again, if you're trying to if you want to try to keep this prosthesis for a longer period of time, and this may be the case for some of your patients that financially cannot afford at the time of treatment, either implants or removable prosthesis, or they just want to stay away from removable prosthesis, but they can't afford the implants, then you may want to build these at a different, you want to build them in your lab. You want to build them prior to the patient getting into the dental chair. So for that particular case, once the patient is in your chair, you have to take an impression of the site. You pour a cast, and out of that cast, you build this prosthesis like you're seeing here on the right hand side. Again, I'm going to share with you multiple cases so that you can see step by step how do I go from either building it directly into the patient's mouth or doing it in the lab setting, and then bringing the patient back for me to deliver the prosthesis. But when I use an indirect type of procedure, I like using this fiber. This is construct made by Kerr, and this is more on their lab side. You see that it says it on the label Kerr Lab. And this is a polyethylene fiber. They make these polyethylene fibers that come in 3 different widths, and you can see that they have their own little kit with the pliers to cut the fibers, the resin to infiltrate the fibers. And again, I'll show you step by step how I go about building these bridges. So let's go into the tip and trick number 2, which is the direct technique using a fiber post. So this is the case that I'm going to share with you. This is my first case today. As you can see, this is a fairly young patient. She had a trauma, and she lost one of her mandibular incisors. As you can see, not only that the trauma caused the loss of the tooth, but also there was a huge collapse in regards to bone in that area. So this patient at this point was not a candidate for implants. She needed to be, she needed multiple graft surgeries on that site in order for us to be able to place an implant. So, while all that is happening, nobody wants to be with this huge gap between incisors on the mandibular arch. And most importantly, for a young patient. So she was, she really wanted something there while we were planning and while she was getting all these surgeries. She wanted something there. The other aspect is that financially, she wasn't ready for, the big commitment of, again, the bone grafts and the implant placements and the final prosthesis. So we didn't want to give her just something that would be there for a couple of weeks or months. We wanted to kind of give her something that would be there for the long run. And, for me, the long run or the long term situation would be, something using some type of fiber. And in this particular case, as I mentioned before, there are multiple ways of doing this. One of them being using a fiber post. And this is exactly what I did for this particular patient. And again, I'm going to walk you through the process, and I also share with you the reasoning behind each and every one of the steps that I'm taking for this patient. So the first thing that I want to do is obviously isolate the area. I want to try to keep the area nice and dry and clean throughout the entire procedure. So for that case, I'm using here two B4 clamps. just to hold. I have two W2s most likely on the premolars, and then I have these B4 clamps on the neighboring incisors right next to the missing tooth area, right? And the reason for that is because what I want to try to accomplish is I want to try to um, you know have a clean area, nice and beautiful clean enamel, in order for me to obtain the best bonding possible. So again, for this case, I selected a fiber post, and this is a fiber post from Parapost, which is made by Coltine, and the reason why I chose a fiber post for this particular case is because the post is already rigid, or it's more rigid compared to a polyethylene fiber that is non-embedded in resin, which is very sometimes difficult to kind of handle within the patient's mouth just to get it nice and even. The other reason is that these teeth are very small. They're not that tall. They're mandibular incisors. I really didn't want the patient. I was worried about having too much bulkiness of resin on the lingual aspect of these teeth, and having the patient put her tongue constantly in these thicker abutment teeth. So by using one of these fiber posts, the only downside is that you do have to prepare small slots on the enamel in order for you to be able to bond this post within the crowns of these teeth. As you can see, the first thing that I do is I want to measure, I want to section, I want to cut the right length of the post, and I'm looking maybe to have 2 to 3 millimeters of the post within the actual tooth structure. So I want to bond that post within these slots that I'm preparing. You can see on the right hand side, I'm using a very small round burr, maybe a number 1 or number 2 round burr, and I'm just preparing these small slots, hopefully within the enamel. Sometimes you do have to get into the dentin again, depending on the location of the post and depending on the tooth that you're trying to restore. But this is a lot more conservative than a 3-unit bridge. It is more it is more aggressive, if you want to use that word, compared to a Maryland bridge. But again, think about the finances of this patient. And that's what I said at the beginning of my presentation. These bridges are an alternative. They're not the best option. They're not a long-term, 10, 20-year option. Maybe in a case like this, it is going to be a really long case. I've had cases like this last 10 to 12 years without any problems. You get a little bit of staining here and there, but it's always easy to polish them. But and the reason why you get this longevity on these specific sites is because of the low occlusal load and very small teeth and a lot of enamel to actually bond to. So this is definitely less expensive than having a Maryland bridge that you send to the lab and be fabricated today with either zirconia or lithium disilicate. This is chairside direct restoration, so you don't have a lab cost for this particular case. And again, I'm trying to earn some or gain some time while the patient is getting ready financially for her graft and for the implant needed on that site. So we prep the slots. Once we prep the slots, you see now I know that this post is going within the slots. You can see on the right hand side, the post hasn't been bonded yet to the neighboring teeth, but it stays in those slots. So the slots are really keeping that post in place. That's how much retention you want to be able to accomplish once you prepare those small slots on both of the abutment teeth. And once that is accomplished, once you have the right length for the post, what I normally do is I go ahead and I acid edge, and because this enamel on the facial and inner proximal hasn't been cut, right now I'm going to just concentrate on etching the lingual side, right? Only the area that I prepare the slots. 15 seconds of etching of that enamel is going to be more than enough, because you have used a burr, so you have cut that enamel and you're able to etch for that short period of time. Then you rinse and dry. And again, once you rinse and dry, you're going to apply your adhesive. And I was only on enamel that didn't have any dentin exposed, so I decided I was actually using OptiBond FL for this case, but I was only using the adhesive portion for the lingual slots. I apply a little bit of that adhesive on each of the slots, light cure them, and at the same time, I have my dental assistant clean or wipe that fiber post with a alcohol swab. The reason for that is because we're always, we're touching that post, we're contaminating it with our hands. There's a little bit of oil in our hands that can go and affect the bonding with that post and the teeth. So what I want to do is I want to make sure that I have it 100% clean. And an easy and predictable way of doing that is just using an alcohol swab, making sure that you get all the any oils from your hands or grease around that post, that is completely removed and nice and clean post. And once that post is nice and clean, then I'm ready to use a little bit of flowable composite and bond that post within those preparations that I created. Right, and the flowable composite is only there to initially hold the post in place. I light cure it, and then what I'm going to do is I'm going to cover all that with just regular microhybrid composite to give it the wear resistance that is needed. So first, you go ahead and you place the post with your flowable composite. You light cure, and once that is cured, the post is it's in place. And you can see there that I'm holding the post with a hemostat, and my assistant is coming from behind the post and light curing that area. Once she light cures, I'm done with actually placing the post, and now I'm going to go to my second step, which is going to start now building that missing tooth that the patient has. So for that, I'm going to go ahead and do total etch technique. In this particular case, I'm going to change slightly my acid etching technique because again, these teeth have not been touched with a burr on the facial aspect, only on the lingual. So the facial is fluoroapatite enamel, so it's more acid resistant. I want to double the etching time, and I'm going to increase that etching time from 15 to 30 seconds. And you can see that I've over etched. So I'm trying to really reach out to that enamel, try to bond as much as I can, because again, I'm looking for a long-term solution using this direct fiber reinforced type of prosthesis. So you want to do the best you can, because again, you may in this particular case, we knew that this is probably going to be there for a couple of years before we can go back and do the graft and place the implant for this particular patient. So now we go ahead and we apply again the adhesive only on the facial and on the lingual, and you can see now that once I apply that adhesive, I light cure, and I'm ready to start building my composite tooth. Now, because in this particular case, I'm working chair side, I'm doing this chair side, there is no wax up, I don't have anything to guide me. I'm using, as you can see on the right-hand side, my finger as a lingual matrix. So I always start doing these bridges with a little stump. And that's what I call it, a little stump of composite right in the center. It needs to surround the post. This is a fiber post, so you still want to cover it completely with composite. The beauty of the fiber post compared to polyethylene fiber is that polyethylene fiber cannot be exposed to the oral environment whatsoever. I don't allow this post to either be to be exposed to the oral environment. But if you have a little bit of the post exposed, it's really not going to be affected by saliva or any type of contamination. But again, you want to make sure that you cover it as much as you can, just because from an aesthetic standpoint and from a structural standpoint, you want to have as much composite bonded to the actual tooth, the enamel of the neighboring teeth, as possible. So that's what you're seeing me do on the right hand side. I'm using my finger as a matrix. I'm actually tapping my composite against my finger. This is for me to create the lingual layer, but also you can see that I've already wrapped all this composite around the fiber post. You don't see the fiber post anymore with my first increment. So now you see I'm done with that initial layer, which is again the lingual layer. And I'm going to use two shades here. I'm going to combine dentin and enamel. So I'm going to go ahead, and you can see that I've done a little bit of a mamelon effect on the incisal edge, just to kind of get a little bit of more light going through my enamel once I'm done with this restoration. Again, I want it nice and smooth. You can see that it's covering the whole post. Look at the amount, look at the connection, the thickness of the connection between the composite and the neighboring tooth. If you look at the incisal gingival connection at this point with this first increment, it's like 3 millimeters. So I do have a really good connector between my single missing tooth and the neighboring abutment teeth. And that's kind of like, you're just kind of following the same principles as you would do with any type of indirect prosthesis. So now I'm going to go ahead and I'm going to start building that tooth. I'm going to start placing more of the dentin. And you can see that I'm trying to shape it. I'm going from the incisal all the way down to the gingival. And I have learned over the years that this is the best way to manage. It's one of the most difficult things to make these type of prosthetic solutions directly into the patient's mouth, is that you get a lot of voids on that gingival aspect. It's really hard for you to get like an ovoid pontic. But work from the incisal edge towards the gingival margin. You can see that I'm able to place my little brush underneath that pontic area and slightly keep it void free and start lengthening slowly but surely all the way down to the incisal edge. At the end, I sometimes use a mylar strip just to make sure that I can pull buccal or lingually, just to make sure that I wrap that composite around and try to prevent of getting any voids there. Because again, if you do get voids, you're going to get plaque accumulation, and any plaque accumulation around these bridges is definitely going to, just help them break down faster. And that's what you want to try to prevent. But this is composite. This is the same material that you would use to do a occlusal or an MOD or an MO type of direct restoration. So this material works and behaves very well within the patient's mouth. But the smoother you get it, the less plaque that you're going to be able to build around it. So you can see now I'm still lengthening. I'm getting right at the incisal edge. I'm now using some enamel shade, and I'm going and just creating a little bit more of that opacity and translucency effect of natural teeth. But at the same time, I'm trying to build that to go slightly towards the gingival. Now I'm getting ready to do my final gingival increment. Don't forget that the patient had recession on the neighboring teeth. So I'm trying to create what we call a double contour, meaning that I'm creating a root surface using composite. And you can see that I've stopped using enamel. And now on the right-hand side, you can see that I have some gingival increment built using only a dentin shade, a very yellow dentin shade, just to kind of replicate what the patient actually had on their neighboring teeth. And you can see this from an incisal view, what it looks like. I still need to add a little bit here, but I have that double contour effect just to give it a little bit more reality. But also look at the thickness of my connectors. These connectors are now at least 5 millimeters thick from the incisal all the way to the gingival aspect of that connector. And again, the thicker the connector, the stronger the prosthesis, the longer this prosthesis is going to last. And all that is just wrapping around that little thin fiber post, which is very, very strong post. And again, very easy to bond to neighboring teeth. Once you're done, building the whole tooth, you go in, you just, use some ET diamond burrs, and that's what you see on the left-hand side. I'm just trying to get, the right shape, the right anatomy. We don't tell our patients that this is going to be a perfect solution. We try to match the shade as best as we can. There's a lot of different thicknesses here that we're using. In this particular case, I did not use a white opaquer, and maybe it would have been a good idea for me to use it. But again, the more layers, the more, room for having, some bubbles here and there. And I want this to be a solid structure. So I try to use the least amount of layers possible, but it would have been a great idea for me to just place a thin layer of a white opaque. If you want to use this for a more long-term solution, you may want to do that directly into the patient's mouth before placing your second dentin and your final enamel layer, which is going to help you give you more of a natural look at the end of your restoration. Once we're done with the finishing, we start our polishing procedures. And again, for that, you've seen many of my webinars. If you haven't, you can always go back and look at our anterior composite webinars where we talk a lot about the shape guards. And these shape guards are really good polishers made by Coltine. And honestly, I mean, I've used many brands out there, but I have yet to find one that polishes as good as this one. It gives you a really nice final glaze actually to your restoration. And this is what you're seeing right here. You can see how shiny that tooth is. Again, the value is a little bit on the low side. It would have probably been better for me to use an opaquer, but this for me is a transitional restoration where I am looking forward for the patient to have her graft and to have an implant placed. But I was able to create that double contour effect, give her that long root surface on that abutment. Again, try to keep it real, and at the same time give her room for cleaning, room for her to get an interproximal toothbrush in those embrasure areas, and keep this area clean, which is going to be crucial for the success of this prosthesis. And when you look at the before and the after, and again, I want you to think about this as an immediate solution, because this patient came to my practice without the tooth, and she left the practice with a tooth. Her tongue wasn't bothering her anymore, because she was sticking her tongue always in this space after the accident, after losing that tooth. So, I just want you to picture that. And I want you to look at the immediate transformation going from not having a tooth to having something there that is now, blocking and giving her back her confidence, because that big space, not only that the tongue would always get in there, but when she was talking, maybe some saliva would go out that huge space also. So again, this is a really good way, easy, predictable, fast, inexpensive. You don't have to do these that expensive in your office. You don't have to make them at a cost that is, it's preventive for your patients to actually get it done. But at the same time, this is a lot less expensive than you making an impression and sending it to the lab and having them fabricate something that your patient can't afford. And what I try to do always in my channel is I try to focus on multiple type of restorations, the most expensive one, but also the least expensive ones, because I know that I'm talking to a large audience, and I know that you also have patients like I do that come to my practice and unfortunately cannot afford, definitive solutions at the time of treatment. And this is one option that will help you at least solve their immediate problem. And my tip and trick number 3 is going to be to share with you an indirect technique. So we looked at the direct technique, doing a chair side, using the rubber dam, doing the whole 9 yards. But there's also a way of doing them in an indirect way. And again, all the patients that I'm sharing with you are patients that, that are financially have a lot of constraints. And, in this particular case, this patient came to my practice after a domestic violence issue, and she got into a fight with her spouse, and she lost both 8 and 9 during that event. So this is now maybe, I don't know, 2 months later. The teeth are out, and obviously she's trying to get her life back. So she comes to me, and one of the things that she wants to try to get her life back is to have teeth. She's going through a difficult time in her life. She's got kids. Financially, she can't do anything permanent there. She doesn't want to have a flipper. And by the way, these flippers are not cheap either. So she doesn't want to have anything removable. She's fairly young. She wants to try to have something fixed, but she can't afford a 4-unit bridge or a Maryland. She can't afford implants. There's a lot of things that are going on, and again, this is real life situations, and I told you just part of the story. I know very well this story. I tell you part of the story just to think about and ask yourself, do I have these patients walking through my door? And if the answer to that question is yes, well, this is a good alternative. So I told the patient, look, this is a big space. You're missing 2 teeth. I love doing these bridges for a single missing tooth. I'm sorry, but I can offer you this option, but definitely this is an option that I'm going to do it. I'm not going to do this chair side, because I just want you to picture this. Doing this chair side is going to be a lot of work, and it's not going to be easy at all. I mean, I don't know if I'm going to be able to accomplish aesthetically what I'm looking for. I really wanted Bond. She had these beautiful cane lateral incisors, I'm sorry, that had a lot of enamel, were completely healthy. So I'm like, okay, I can bond, I can fabricate something in the lab, in my office. I can fabricate something in the lab setting in my office, and I can have her come back and bond it directly into her mouth. Now, when I do something like this, again, I want to build this massive block of composite with fibers so that I can reinforce them and then bond them directly into the patient's mouth. So for a case like that, what I do is I normally make an alternate impression, and I'll show you another option also that I did at the Dental College of Georgia with one of our students. She did a great job, and I do want to share her case with you because she had this great idea that I thought it was, a good solution, a good quick solution for, making an impression and pouring a cast and allowing the cast to set and then having to do a wax up. You have to do this. So what I did is I made the impression, I mounted my cast, I looked at her occlusion. You can see that her mandibular incisors had a vestibular incline. So she was like an edge to edge type of patient. I knew I couldn't get her. I didn't want to give her like a really nice overlapping central incisors, because that would put a lot of load on those incisors. And I wanted to have all the load on 7 and 10. So, very light load, protrusive is going to be on 7 and 10. I want to keep the occlusion on these teeth very light, because they're going to be held just by bonding, which is excellent. But, this is all made out of composite. There's no glass here, just composite and some fibers. So after the wax up, what I like doing is I make a lingual matrix of my wax up. And with that lingual matrix, to know exactly where my lingual contour should go, I start building this in my office. And this one I did myself, but this is something, again, I've had in past times, really well-trained dental assistants that can do this. If you have a lab tech in your office, they can definitely do this for you. And this is just using regular composite. I mean, I'm not using any special type of lab composite. This is just regular every single day composite syringes that you have already in your office. So there's no other thing that you need to buy than the fiber if you don't have a fiber. In this particular case, I am going to use a polyethylene fiber, and you can see that I've built now this massive solid block of composite, which is really, really cured. I actually placed this in my office. I had one of these ovens, like a triad oven for composite. And what you can do is that once I first light cure it outside, just with my hands initially to get it nice and stable, and then I put it in that oven for 5 minutes, and I put it on inside a glycerin container so that there's no oxygen. It's fully being polymerized. I know that I'm getting. I mean, I felt that when I'm polishing, when I'm finishing these prostheses, this composite is much harder than when we do it directly into the patient's mouth. So I'm not going to say that this is 100% polymerized, because it's not, but I do know that I'm up there between, I would say 75 and 80% of the polymer completely polymerized, just because I'm using a lot more energy, I'm using a lot more time, and I'm submerging them in this glycerin so that I don't have any oxygen while that is happening. So I try to do the best I can. And you can see that I've created some wings on the facial. I'm going to create some wings on the lingual. And then once this massive and solid block of composite is built, then I go ahead and you've seen that I've left this space there for me to add that fiber. So now I'm going to go ahead and wet this fiber with resin, mix it with flowable resin, and the same microhybrid resin that I used to build this prosthesis. And I'm going to just make it blend in well and connect it to the whole prosthesis. Now, because this prosthesis is in your hands, you can go back in, add a little bit of composite here and there, fill any voids that you have. As you can see, there's a couple of voids on the lingual that I've had. I'm going to go ahead and fill those areas very nicely, and then you're going to go ahead and polish it. So all this is done outside the patient's mouth. So now you bring the patient back. You have that prosthesis in your hand, just like having a Maryland bridge done on ceramic. The only difference is this was done with composite. So this is immediately after bonding my prosthesis. You can see on the left-hand side, nice texture, but I want you to look at the way that I was able to make these wings on the facial of 7 and 10 blend in with the whole prosthesis. Now, this fiber, this was bonded on the facial aspect with the wings, and on the lingual, that fiber that crossed the whole lingual surface of both 8 and 9 extended all the way to at least 2/3 of the lingual surface of 7 and 10. Which means that there's a lot of bonded surface, buccally and lingually, and the fiber to keep the whole structure, sturdy and strong. Again, you can see that I shortened 8 and 9. They're shorter than 7 and 10 because I want, this is edge to edge, almost occlusion. Any movements are going to be on her canines. Any disocclusion is going to be on the canines and the laterals. I don't want to do any of 8 and 9 because I know that this is not as strong as ceramic. But the goal and the idea is to, allow the patient again to financially get on her feet, get her life back, do the other things that are also important in life, and most likely more important than having two teeth in your mouth, two expensive teeth in your mouth, is when we give this as an alternative and as an option. And again, this I would not call this a long-term solution, but I do call it I do want to say that I feel confident to call this a long-term temporary solution, which is not the same as a long-term solution, which is a final solution. This is not a final solution. This is an interim solution. This is very easy to repair if it will ever fracture. It's very easy to repair. And one of the things that I have found over the years, because I've been doing this for many years, is that if these longer bridges, and I don't really do a lot of two teeth, I have done a couple of cases. The majority of my cases are single tooth, and those single tooth are very, very predictable. But these are not as predictable as having a single tooth because there's more occlusion on them, obviously. But if they ever fracture, the fiber that's within this prosthesis keeps everything together. So it's very, very easy for you to repair. So again, worst case scenario, you repair it and you have something. At least the patient doesn't have to remove this. There is nothing in their palate. There is no clasp or wires. If you gave her like a flipper option, this is a direct fixed option made with composite, indirectly made. So this is a indirect prosthesis done in a lab and bonded at a separate appointment. And this is one way of doing these prostheses. And again, if you look at the before and after, you can see this photo on the right hand side was probably taken 3 to 4 months after the patient was using the prosthesis, still in really good shape, hadn't fractured at all. You can see I allowed a little bit of embrasures between the laterals and the centrals so that she can go ahead and clean it. She's trying to do, she's doing a good job trying to keep it clean. But most importantly, she's functioning and she has her life back. She has her smile back, which is so important. Again, this is a lingual view of the prosthesis. You can see there's a little bit of a space between the prosthesis and the tissue so that she can get a little floss underneath them. You can see how they are connected, more than 2/3 of the lingual surface of 7 and 10. And the prosthesis, you can see the fiber going all the way through, crossing the bridge from one side to another. So again, really, really good alternative for I would say a quick solution for a big problem that requires a lot more dentistry than what you're seeing right now. This is a very, very conservative alternative. And this is the day that this photo was obtained, the same day that I delivered the prosthesis. And I want you to evaluate the smile right before she sat down in my chair, right after we delivered that bridge. This is really life-changing for many of our patients. And that's what I want you to think, because I know and I'm sure that some of you out there listening to me today have these kind of patients in your practice. And my last case for today is going to be this one. And I really want to give credit to Miss Ashton Young. She's one of our DS4 students at the Dental College of Georgia. And I had the honor and privilege to work with her. This is now a case that probably has a year now of a follow-up. I don't have the follow-up photos, but I'm sure that Miss Young is still has this patient in a population. Is most likely she will be able to get at least a year follow-up photo, if not more. I think that probably is going to be a little bit even more by the end of this year of follow-up for this particular case. And she came to me. We had this patient again. Look at the defect. This is now an older gentleman. He didn't want to have anything fixed. Both of the lateral, the central and the lateral incisor that are neighboring this edentulous space are healthy. They don't have any restorations. You can see that he's got a large defect in that area. He would need, multiple surgeries, not only bone graft, tissue grafts, and then an implant. And, some patients just, even if financially they can do it, they just don't want to go through that long and process. I mean, this is just reality. I'm not saying that one option is better than the other. I think that the implant option would be an excellent option for this patient. I think if we have a really good periodontal surgeon, see this case and do all our gingival grafts and our bone grafts and get all the architecture back to where it needs to be, and when they place an implant for us, by all means, why not do it? I mean, it is a great and excellent option, but it's not an option for every single patient. And some patients just don't want to go through the burden. They just want to have something, they'd rather have something quicker. And I think that this is a really good, low cost, very conservative alternative. And the way that Miss Young did this case is really what I want to share with you, because I think that she had a phenomenal idea. She went ahead and she made an impression with PVS, and instead of pouring her impression in a cast, a stone only, she poured it first using GI mask, and this is the pour that you see on the right hand side. And if you think about it, GI mask is actually used in dentistry to recreate tissue around implants in our impressions so that you can get the correct emergence profile. So this material doesn't stick to the PVS. It's very easy to kind of, separate. And that's what she did. She went ahead, she did all the steps needed with the GI mask, and she used it to pour the impression first. She removed it and she obtained this cast, quote unquote, made out of that GI mask. If you think about it, GI mask is very flexible. It's a silicone-based material, and it does not, and nothing is going to stick to this. So I thought it was a great idea for her to fabricate the prosthesis in this GI mask model, because it's very easy to not, when you're doing this on a cast, believe me, composite sticks to the cast, and you have to clean your prosthesis afterwards, and the cast can actually break. This one is so flexible, you're not going to break anything. So she poured it first on the GI mask, and then she went ahead and poured it on stone. So here you see both pours, the stone on the left-hand side, the GI mask on the right-hand side. Then she went ahead and did a wax up. And she did a beautiful wax up. You can see that in her wax up, she fabricated these two wings. And those wings are meant to, when she's bringing down the prosthesis, she knows exactly where to stop. Again, this is textbook protocol. And that's what I like about her case. Textbook protocol. She's a very young dental student. She's never done this before. So we wanted her to follow a really, really good protocol. And this is not only me, this is me and Dr. Bill or William Brackett. He is one of our professors in operative dentistry at the Dental College of Georgia as well. I'm not at the dental school anymore, but he's still my really good friend. So, between both of us, we're trying to help her and give her like the straightforward step-by-step technique so that now she can accomplish a really good result, even though it was the first time that she did it. But she has all the credit in regards to the clinical and laboratory aspect, but she did all this on her own. So she waxed the tooth up. She then made a PVS impression of the wax up tooth, and then transferred that PVS facial impression to the silicone model, as you can see on the right hand side. So now she's got that template so that she can get the right anatomy for that tooth, exactly like her wax up. So this is, again, a brilliant idea. There you see the fiber. She's using a polyethylene fiber. She's using Construct from Kerr. You can see that she's bonded that fiber. We're using here like the 3 millimeter width of fiber. And she's wetted with resin, and now she's made it rigid. And you can see that one thing that is critical is that fiber, and that's why I like these polyethylene fibers. You go in and you have to model the fiber. The fiber has to be on the lingual surface of one tooth, then make a slight turn to the mesial surface, continue straight to the opposing abutment, and then again make that little curve around the mesial lingual line angle to the lingual surface. So it's not a straight piece of fiber. It has to follow these contours, because you're going to bond this again directly to the patient's mouth. You want to have intimate contact on those connector areas. So now she's added the composite to her prototype, to her matrix. I'm sorry. She's added the composite to the matrix, and she sits the matrix back. She's got beautiful area to light cure right through the lingual aspect and hit that composite and make it get completely polymerized, and then continue adding composite to the facial and the lingual until she's done with her prosthesis. And you can see that then she transferred the prosthesis from the silicone model to the stone model. She makes sure that she gets all her wings, so she's got a really nice stop. She knows exactly where she needs to stop, and then you'll cut these down. You just smooth them down with a softless disc once the prosthesis is bonded. And the other thing is that she was going to do the extension of the gingival extension was going to be done chair side. So because again, it's kind of hard to. She could have done it on the model, but she wanted to do it at chairs. She wanted to do it chair side just to get a better adaptation to the gingival tissue, and I thought that was a great idea. So there she goes. She's now bonding the bridge. You can see that she's got good isolation. She's bonding the bridge. You can see the embrasures. Look at the surface connectors. You can see these both of the mesial and distal connectors are at least 3 to 4 millimeters wide, but the patient still has nice embrasures to go in and be able to clean that area without any problem. So now the prosthesis is completely seated. It's been bonded. We normally just bond it with flowable composite. You can also bond it with warmed composite, or you can use any type of resin cement, but you definitely want to bond this. You want to acid edge, prime and bond, because you want to take advantage of the amount of enamel and the bond strength to that enamel. And again, she's got a couple of follow-up photos. You can see that she was able to accomplish really nice adaptation of the prosthesis to the gingival aspect. Again, this was a final prosthesis for this patient. This wasn't an interim prosthesis. This wasn't us waiting for a graft or an implant. This was the final prosthesis. I know this prosthesis is going to be there for a long time, as long as the patient needs it, because it has a lot of enamel to bond to. It has very wide, thick connectors to the abutment teeth, is highly polished, so plaque is not going to get around it. The contours are ideal. It has room for good maintenance and cleanliness of the patient on those gingival embrasures. Everything needed in these prostheses to be able to succeed. And again, if you look at the before, the photo on the right hand side is at least 30 to 60 days after, and you can see how now this tooth has just blended in the patient's smile. He's extremely happy because it was a low cost, indirect the restoration that is easy to maintain, that if it ever wears or stains, is easy to polish or repair. So it's very, very easy for the patient to maintain, and it's even at a low cost if needed, because I don't really see these type of prostheses needing a lot of maintenance when they are fabricated on the mandibular incisors. And I would say second place would be the lateral maxillary lateral incisors.